Good evening. Hi, welcome to the Royal College of Surgeons of Edinburgh's webinar series in simulation working. This is the fourth in a series that has been put together by the college to look at all the aspects of simulation in surgical training. I'd like to welcome our three speakers. The first who will be speaking is Professor Ken Walker, who's a consultant colorectal surgeon in Raigmore. He's Associate Director of Medical Education in NHS Highland and is the ISD simulation lead in NHS Education for Scotland. Our second presenter will be Michael Moneypenny, who's going to draw on his wealth of experience as both a consultant anaesthetist in Forth Valley Hospital and as Director of the Scottish Centre for Simulation and Clinical Human Factors. And finally, our third speaker is Jennifer Cleland, who's Professor of Medical Education Research, formerly in Aberdeen, but she's now relocated to Singapore. And we're really grateful for her for speaking today because it's 2 AM in Singapore and she's looking really well on that. I'd like to encourage you to put questions onto the chat format for the webinar so that we can go through those questions. We'll have questions after each talk and some more time at the end. I'm Alison Lanigan, I'm the Vice President for the Surgical College in Glasgow, and I'm part of the Simulation Collaborative that we have in Scotland. And I'm going to now invite our first speaker, Ken Walker, to share his slides and talk to you. Carry on, Ken.
Yes, so thanks very much, Alison, and I hope you can see my slides there. In this last part of the series, we wanted to cover three key areas that we think make simulation work, and in the previous webinars in the series, we've really covered a lot of possibilities in surgical simulation. Quite an impressive array of possibilities, possibilities for training in technical skills, also cognitive and social skills, even attitudes actually, and I hope you're convinced by now that simulation in surgical training is an essential rather than an optional adjunct to our precious apprenticeship style training, and that to do without it would be like a musician who only practices during a gig, or like somebody coming for cancer surgery who declines the adjuvant therapy. But the situation in the UK, as we said in the introductory webinar, remains that simulation is not as fully integrated as it is in other high reliability, they used to be called high risk industries, nuclear power, civil aviation and so on. It's mainly in courses, it's often good quality, it can be optional and tends to be paid for by the trainee, or at least it exceeds their £500 a year study leave budget, which doesn't seem right. And this is in the era where we're already well into the era where we're mass producing surgery. The average person in a high income country has 7 operations in their lifetime. So in that introductory webinar, we looked at a list of what could be our excuses that we haven't fixed this yet. And I wanted this time to expand on a few of those a bit further, particularly this business about lack of longitudinal strategy, a little bit about the cost, and something about mandating. And we've been asked a lot of questions about that since the first webinar. Just to quickly recap, I think we dismissed lack of evidence as an excuse for not having fixed this yet. And Jen will be speaking with us later about types of evidence, I guess. You know, a lot of people had said, well, it's more complex than it is in civil aviation. For example, you know, I'm like the pilot who, I don't just fly the plane, I have to run the travel agent and the check-in. It's like I'm running the hotel afterwards as well. But I hope you were convinced by some of the presentations we heard from military simulation that you can simulate to a high degree of complexity in multiple different roles. The facility, we made the point before that actually you don't need a lot of high tech to achieve high fidelity. And I just wanted briefly to expand on that again, that fidelity is emerging as a rather misused word. We should be talking not so much about high and low fidelity as about psychological or functional or physical fidelity. So here, for example, is quite a simple tabletop simulation from a boot camp, but with a high degree of psychological fidelity. Here's another example, which is the Black Belt Academy of Surgical Skills that David O'Regan runs and you can access online. And here we've got a model which has a high degree of functional fidelity. Trainees can be doing this at home on an ironing board with a banana. So a simple model, but actually a high degree. And so you can have a very, that's a very artful and thoughtful simulation training course, but it doesn't need to be high tech. But where we do need high tech, the other point is that it is available in our deaneries. So I think we dismissed lack of facility as an excuse. Faculty development, we maybe do have a way to go, and Michael's going to be talking about one important aspect of faculty training later on. I'll not spend time on that just now. Rather, I'd like to expand on this business of how do we develop our strategies, how do we see simulation integrated into the curriculum of a surgical training program. Or as Barry Issenberg from Miami would call it, curricular institutionalization, one of the essentials for success. We used the example before of the simulation strategy that we're piloting in the Scottish Core Surgical Training Programs, in the Improving Surgical Training pilot just now, which was drafted by our Scottish Surgical Simulation Collaborative that Alison's on, and Jen as well. And I thought I'd just let you into a little glimpse of how that process worked, how that collaborative drew up a strategy. And ultimately what you're aiming for is this concept of constructive alignment as depicted in this diagram. And you can see that before you begin to think about your interventions, you really need to be clear about your intended learning outcomes. So you need to be clear about your needs and the curriculum. So it's got to be mapped to a curriculum. And there are new curricula coming out in August 2021, as many of you know, in our surgical specialties. But my top tip is don't map to all of it. Only map where simulation is going to help. Okay? And don't map to it in too detailed and granular a way, or we'll be back to the same problems we've had with PBAs. And I think that actually the new curricula where they have these competencies in practice or entrustable professional activities that we spoke about the other week, which are much more overarching competencies that we're aiming for, I think that will help. But as well as mapping to the curriculum, we found that you've got to map to your existing resources, what you already have, if you're going to hit the ground running. And knowing what you already have is actually quite a lot of work. How many of you knew until I mentioned it that BBAS was available online? Or if you're an ophthalmologist, how many would know that there's this fantastic cataract training program in Gloucestershire that's been developed there? So knowing that stuff and then filling the gaps is important. And my final tip would be over time, as you implement your strategy, to observe not only the stated learning outcomes, but what other incidental and more nuanced learning is happening during the thing. And that's something that Jen will talk about later. So this, I know you can't read it, but it's just to show you the working sheet when we had when we were drafting a strategy in our simulation collaborative. This was one we were asked to do for a notional 6-year run-through program in general surgery, which came out of the Shape of Training review a few years ago. And so that theoretical training program was based around these entrustable professional activities, which are things like running an outpatient clinic, running a trauma on call. And one of them is this, running an operating list. So you can't read it, so let me expand that one. And you'll see that that's the entrustable professional activity. Here are the competencies required. We've highlighted in blue the ones that can help with simulation. And then we've started to list across the 6 years our interventions. And we've put in green the interventions that already exist. In orange was those that we had in the pipeline at the time. And in red, those that we thought we would need to develop from scratch. And you can see that's an encouraging place. You might find yourself there that if most of your screen is already green, then you're going to be able to hit the ground running, and you're going to concentrate your efforts on the new things as well as supporting the existing things. So that's just a little glimpse as to some of the process of developing a strategy. And I think we need a lot more strategies so that trainees know trainers doing the right thing at the right time rather than varying too much from trainee to trainee and year to year. The other thing I wanted to expand a little bit on was the cost question. I mentioned before, that simulation strategy, which is quite comprehensive, came in at £2,000 per trainee per year, and was funded by the Scottish Government. Now, I'm not able to show you an exact balance sheet against savings to the health service, but I can have a stab at some predicted savings. So, for example, there will be savings to the service. In purely financial terms, never mind patient safety and human cost, in purely financial terms, if, for example, a trainee hastens the day when they reach the point, because of their training in the motor skills and laparoscopic surgery, where they can do 3 laparoscopic cholecystectomies instead of 2 on a list, that's a saving every list from then on of £1,563. So even if that applies to only 2 lists in a year, that pays for their whole simulation training program for the year. Other savings might be to society. As Mark Slack said last webinar, as a society, we are already paying the cost of inadequate training. So if, as a result of our training program, over the course of some years, a middle-aged person has their life saved, somewhat coldly but necessarily nice, put a value on one quality adjusted life year for the purposes of health economic calculations, and it was £25,000. So if you save a middle-aged life, you might save £750,000. Well, that would pay for a simulation program like this for 50 trainees for 7.5 years. These are not exact predictions, but they give you a sense of scale as to what the predicted savings might be. And there are pieces of work from around the world that are in more detail. So, for example, Mastery Learning, a group in Chicago, have developed this. Michael probably knows more about it than me, but Mastery Learning is a particular way of doing simulation where you define a standard and train to that standard. And they've been very good at following through in terms of cost effectiveness, following through to clinical outcomes. They have some very impressive data around different procedures, which now include exploration of the common bile duct, a surgical procedure. In Boston, it was CRICO, the defense union, in fact, their actuaries, who told them that they should pay for their members to do team training and simulation, and that they should give them 10% discount off their annual premium because they predicted a reduction in litigation costs. And 10% in America is a lot. And in Wales, the only other example I know of a UK government putting money directly into surgical simulation because they were so impressed with the ophthalmology data from John Ferris and others about the reduction in complications as a result of the ISI VR training program there. So there are other examples that justify putting money where our mouths are, even if we don't have all those level 4 outcome data. And the final thing I'd like to mention before handing back is, we've been asked a lot, why haven't we mandated this? Why isn't it just mandatory? And the JCST actually asked the GMC about 4 years ago, will you mandate this? Because the GMC is the regulator. And the GMC said, well, no, we're not going to do that just now because we're not bothered about very high quality on the menu like this fancy restaurant. We're more concerned, is it universally available like this restaurant over here? Is there a McDonald's on every corner? And there wasn't. And I said, we can't mandate something that's not going to be available. And it's a bit of a catch-22 because things maybe don't become available until they are mandatory sometimes. But that begged the question, okay, so if they're not going to mandate it, whose job is it actually to see this through and get it into training programs? And a trainee asked me once, who runs surgical training in the UK, and I tried to draw them a diagram of who's responsible for what. I think I tried to show you this once, Jen, and it's quite complicated. And in fact, I'm amazed by colleagues who work in that landscape, all the different organizations, who's responsible for setting standards, who's for governance, who's for delivery, who's for regulation and so on. Amazed that people get anything done, and in fact, amazed at how agile they were during COVID times in particular. But it is a hard landscape to work in, and I just wonder if it's this that's our complexity rather than simulation. And I think it would be a shame if we're failing to finally get there and integrate simulation into our training programs just because of this. And so in closing, I'll tell you just what I think made the difference for us in getting a strategy into a training program. And I think it was these points. A Simulation Collaborative had done the homework with the programs and the TPDs and all the stakeholders and had a proposal ready to go. Scottish Government, when the Improving Surgical Training pilot came along, Scottish Government bought in literally, so they agreed with the rationale and funded it. And I think, although it didn't need to be much money, I think it made a crucial difference that the health service invested. And we were able to get a project team around it as a result. We effectively internally mandated it in the programme. We couldn't insist on anything different being required at ARCP because these are UK national requirements and we didn't want to disadvantage any trainees, but in effect we were mandating attendance to a proportion of the simulation interventions in the programme. We did something about faculty development and there's a validation study ongoing, which I don't know if Jen will mention. I'm sorry if I've gone over time, but I think that's what made the difference in getting a strategy going. Thanks.
Thanks, Ken. That was really interesting and a really good recap of where the Simulation Collaborative took the ideas about embedding simulation in training. But as you can imagine, there are lots of obstacles, and that picture that you show of all the blobs of the different people who organise training and assessment and try and coordinate all training is really useful. I've got some questions here, many of which you've actually addressed. I think the first one from Angus Watson was, can we afford not to mandate simulation? I think some of your figures have already answered that, but do you want to expand on that just for a second or two?
Yeah, I think the most compelling thing for me is the cost to society. Another quote that really moved me along was from our lay representatives when we did a consultation, you'll remember, Alison, in 2015. And they were astonished that we hadn't fixed this yet. And one of them said, there's a lack of embarrassment that this is not fixed. I think we can look them in the eye a little bit better now than then, but we have a way to go before it's integrated, like in civil aviation or in nuclear power industry.
I think looking at that picture you have of the 6-year programme that we looked at, and whilst we're really encouraged about the green and amber areas, some of those red areas have now been addressed too. Like you, I think that it's been internally mandated, as you put it, but not necessarily externally mandated and costed. One of the other questions